Welcome to the Deep Dive, where we take some of the most comprehensive, scientifically dense source material and really distill it into the crucial, actionable knowledge you need. Today, we are deep diving into an atlas of gynecologic oncology. We're pulling out the foundational science and practical surgical wisdom that separates good practice from excellent practice.
That's exactly right. For any medical student or resident or a young professional listening, this deep dive is a shortcut.
The shortcut.
Yeah. Our mission here is to synthesize the foundational principles, the technical demands of these really complex procedures, and the absolutely non-negotiable safety protocols you need for managing gynecologic malignancy. We're starting at the ground floor.
Okay, let's unpack this by starting where every surgical discussion really has to.
Yeah.
Patient safety and preventing complications. I think we have to address two giants here: infection and thromboembolic disease, or TED.
Absolutely. So infection prophylaxis is, it's mandatory in this field, and the data clearly supports that.
And it's pretty stark, right?
It is. I mean, if you look at a procedure like a vaginal hysterectomy, published infection rates without routine antibiotic prophylaxis can climb as high as 38%.
38%. That's a massive, massive operative risk. So who are the patients that need extra attention? What flags them as high risk for a post-op infection?
Well, beyond the obvious factors, the sources really highlight that the operative details matter.
Yeah.
A lot. We look for procedures lasting longer than 3 hours,
Okay.
blood loss that exceeds 1,500 milliliters, and very critically, morbid obesity. Those specific challenges significantly increase the likelihood of a post-surgical infection.
And when we talk about the antibiotic regimens for this, are we looking at long courses to try and, knock out all the flora? Or is it a more targeted approach?
It's highly targeted. The consensus really favors short courses, a maximum of 3 doses.
Just 3.
Right. The goal isn't sterile eradication. It's an effective reduction of the local flora using agents like first-gen cephalosporins, broad-spectrum penicillins, or metronidazole. The balance here is key.
Yeah.
Efficacy, cost-effectiveness, and, minimizing the risk of promoting antimicrobial resistance.
That distinction reduction, not eradication, is so important. Okay, let's pivot to TED. Gynecologic oncology patients, just by the nature of their disease and treatment, are high risk.
Yeah.
What does the data say about that baseline risk?
It's high. If prevention measures aren't there, these patients face a 40 to 70% chance of developing TED.
Wow.
Yeah, that places them firmly in the high-risk category, which means you have to use aggressive and appropriate prophylaxis.
And here's where it gets really interesting, right? The choice between standard unfractionated heparin, UH, and low molecular weight heparin, LMWH. The source material strongly favors LMWH here. So why is that? Why does it solve that efficacy versus bleeding paradox that UH seems to have?
That's a great way to put it. It is a paradox. See, with low-dose standard UH, usually given twice a day, it's often just inadequate for high-risk cancer patients.
Not enough protection.
Exactly. So you think, okay, let's increase the dose or the frequency, maybe 3 times a day. But when you do that to achieve efficacy, you significantly increase complications like wound hematomas, the need for blood transfusions.
You're trading one problem for another.
Precisely. And that's where LMWH overcomes this. Its superior bioavailability means we can get reliable systemic protection with just a single daily dose. This minimizes nursing effort, it helps with patient compliance, and critically, it's associated with less postoperative bleeding and less thrombocytopenia. It's really the ideal agent for this group.
And a quick but vital point on mechanical prophylaxis for, say, lower risk scenarios, things like compression stockings. They have to be applied properly.
Absolutely vital.
Yeah.
Especially in our obese patient population, if the stocking rolls down and constricts the leg, it creates what we call a tourniquet effect. This isn't just ineffective. It can actually increase venous stasis above the constriction, so you're paradoxically raising the risk of TED. Sizing and application are everything.
Let's move our attention to universal precautions, the safety of the surgical team. We often focus on HIV risk, but the source material reminds us that hepatitis B or HPV poses a much greater threat in the OR.
The quantified risk is startling. I mean, while HIV seroconversion from a single accidental stick is low, maybe 0.1 to 0.36%,
Right.
the risk for HPV can be up to 35%. And this is if the source patient is an HBag carrier, meaning high viral replication, maximum infectivity, and of course, if the surgeon isn't already immune.
That's a huge difference. It really underscores the need for routine vaccination and clear protocols. So what are some simple, universally applicable measures we can implement based on the procedure itself to drastically cut the chance of a sharps injury?
The philosophy is universal precaution based on the task, not the patient. So simple but effective things. Using specialized blunt tip needles like a Protect Point or Ethigard where you can.
And double gloving.
Yes.
Yeah.
We have data showing that routine double gloving diminishes the inner glove puncture rate sixfold.
Sixfold. And then there are the basics. Hands-free surgical sharps boxes must be used, and if a sharp is dropped, you retrieve it with a magnet, never by hand.
And in the worst-case scenario, if an accidental inoculation does happen, what does post-exposure management look like for HIV?
So post-exposure prophylaxis, or PEPA, is a medical emergency. It has to be initiated extremely quickly, ideally within 1 hour.
Or 1 hour.
And it involves multi-drug antiviral therapy. The specific drugs listed here are AZT, indinavir, and a protease inhibitor like 3-TC. The key principle to understand is that this is combination therapy. It's necessary to maximize efficacy. Okay, moving from general safety, let's transition into the core surgical domain. The critical anatomy for radical procedures in the pelvis. And this isn't just about naming structures, is it? It's about navigating surgical planes.
Exactly. When you're doing radical surgery, distinguishing between fascial planes and these avascular spaces is absolutely paramount for safety. You have to start with the organizing framework of subserous connective tissue, which is called the corpus intrapelvinum.
The corpus intrapelvinum.
Right. And this tissue organizes itself into pillars, the uterovaginal, the bladder, and the rectal pillars.
And within that network, the cardinal ligament is probably the most recognizable anchor point.
It is the defining structure. The cardinal ligament is the strongest thickening of the pelvic fascia. It's the primary connection between the uterus and the lateral pelvic wall. Safe dissection relies on identifying key spaces, like the vascular rectovaginal space and the perovesical space, which is limited posteriorly by that very strong cardinal ligament and the uterine artery.
So these spaces are like the surgical highways.
That's a perfect way to think of them. They're the highways you need to navigate safely.
The section on vascular supply also brings up an important safety net, that the rich collateral circulation in the pelvis means most individual vessels can be interrupted safely.
That is a foundational principle, yes, but it comes with a very strict rule.
Which is?
You must preserve at least one of the 3 primary pelvic blood sources, the superior mesenteric artery, or SMA, and the 2 hypogastric or internal iliac arteries. At least one must be preserved.
Okay, that makes sense. Moving to neural structures, what are the 3 nerves most vulnerable during these gynecologic procedures, and how do they get injured?
Okay, first up is the brachial plexus. This is often injured not by dissection, but by patient positioning.
Positioning, how?
Specifically, excessive superior traction when the patient's arms are extended for laparoscopic access. Just too much pull.
Okay. And the second nerve risk. You said it was related to retraction during deep abdominal work.
That's the femoral nerve. It can be compressed by deep abdominal retractors resting over the psoas muscle. And interestingly, the source also notes that during some vaginal procedures, an assistant just resting an elbow on the medial anterior thigh can cause that same compression injury.
And if that's damaged, you lose leg extension and hip flexion.
Correct.
And finally, the nerve most commonly associated with lymph node dissection.
That would be the obturator nerve. This nerve is highly vulnerable to transection during aggressive lymph node removal as it runs right near the dissection fields. Injury there results in the loss of leg adduction, which really affects the patient's gait.
Now we shift gears to diagnostics, specifically the role and limitations of cancer antigen 125, CA125, in ovarian cancer.
Right. CA125 is the best-known marker. It's elevated in about 83% of epithelial ovarian cancer patients. However, and this is a crucial limitation, it's not sensitive enough for early detection.
How so?
Only about 50% of stator cancers show elevated levels. So a value below the standard cutoff of 35 or even 20 can't reliably exclude active disease.
So relying on CA125 alone for screening would miss a lot of cases. How is it best used then?
It shines as part of a multimodal strategy. When you combine a CA125 assessment with pelvic ultrasonography, especially in postmenopausal women, the combination achieves extremely high specificity.
How high?
Up to 99.9%. It minimizes false positives, and it's a much more robust screening tool than either one alone.
Quickly, before we move on, what other markers should learners be aware of in this oncological context?
We use SCC antigen for squamous cell cancers of the cervix, vulva, and vagina. And while it's less common, UGF or beta core, a derivative of HCG, is used for some cases of endometrial and vulvovaginal malignancy.
Okay, we're moving now into some of the most technical and complex procedures. Let's look at fertility preservation, specifically radical trachelectomy. This allows patients with cervical cancer to retain their potential for future pregnancy. What's the difference between the vaginal RVT versus the abdominal ROT approach?
Both procedures successfully remove the cervix, the perimetrium, and the upper vagina while preserving the uterine fundus. The radical vaginal trachelectomy, or RVT, is really reserved for a highly selected, ideal subset of patients.
What makes them ideal?
Small lesions, specifically FIGO-stage IA2, IB1, and no evidence of lymph node metastasis. We have successful pregnancies reported after RVT, so we know it works for that group.
The abdominal approach, RAT, it sounds like it introduces some significant vascular challenges.
It does. Radical abdominal trachelectomy is structurally similar to a radical hysterectomy, but it requires dividing the uterine arteries.
Right.
To preserve the uterus, those skeletonized arteries have to be meticulously reanastomosed, surgically reconnected. This involves specialized microvascular techniques and irrigation with heparin. It definitely increases operative time, but success rates for the microvascular anastomosis are quoted as high as 99%.
Incredible. Shifting to recurrence, let's talk pelvic exoneration. This is an extensive procedure developed way back in 1948 by Brunswick for central recurrent cervical cancer after radiation has failed.
Exenteration is massive surgery. You're removing multiple pelvic organs. However, it is still a potentially curative option. The sources cite an acceptable primary mortality rate of 3 to 4% and a long-term survival or cure rate from 30 to 60%.
That's quite high for such a dire situation.
It is, which shows its value in highly selected cases.
After a resection that radical, the key problem becomes managing this. This empty, often previously irradiated pelvis. The risk of small bowel adhesion and fistula formation must be huge.
It is, and managing the empty pelvis is critical. The preferred reconstruction technique is mobilizing the omentum as a transposition flap.
A flap?
Yes, it's secured like a soft trampoline over the pelvic floor. This omental graft serves two indispensable purposes. First, it provides therapeutic angiogenesis, a new, healthy blood supply to that devitalized field.
And second,
it physically separates the remaining small bowel from the raw pelvic tissue, which drastically reduces the risk of fistula.
that concept, using transposition flaps to bring in new blood supply, seems central to the highly specialized procedure for pelvic sidewall recurrence, the LEEP protocol. Can you break down the components of that?
This is a highly engineered, multidisciplinary approach. It starts with LEER, which is laterally extended endopelvic resection, for managing a unifocal sidewall recurrence up to 5 centimeters.
And if the resection margins from LEER are microscopically positive, meaning there's still disease there,
Then we move to court compartmentalized radiotherapy.
what does that actually entail?
Court involves 2 stages. First, titanium guide tubes are precisely implanted directly onto the remaining tumor bed. Second, a pelvic wall blasty is performed using an autologous flap, typically a VRAM or tramp flap harvested from the patient's own tissue.
And that flap is transposed into the defect.
Exactly. This is crucial because it provides that therapeutic angiogenesis we talked about, and it creates several centimeters of physical distance between those guide tubes and the remaining hollow organs before high-dose rate brachytherapy is administered through them. It's an approach designed for maximum local control and minimum collateral damage.
That truly highlights the complexity of the field. Let's wrap up by addressing complication management and, maybe most importantly, communication. For instance, urogenital fistulas. Why do they typically show up 5 to 14 days after surgery?
That delay is the clue. In developed countries, over 70% of urogenital fistulas follow pelvic surgery, and their appearance days later tells us they're usually the result of tissue necrosis or devascularization.
So the blood supply was compromised, it wasn't a direct stitch or injury during the operation?
Exactly.
What are the principles of a successful surgical repair, especially when you're dealing with tissue that's been irradiated?
The principles are tension-free suturing, wide mobilization of tissues, rigorous avoidance of diathermy, and using only absorbable sutures. Now, if the fistula is secondary to radiation, where the tissue is heavily devascularized, an interposition graft, like the omentum or a Marcius labial fat graft, is generally mandatory to bring in a healthy new blood supply.
Finally, the complexity of all this demands a highly refined communication approach. How has doctor-patient communication in oncology evolved?
Oh, it's shifted dramatically from professional paternalism, where the doctor dictates treatment, to informed shared decision-making. The source material introduces a really practical framework for these difficult discussions, the four-cusp approach.
The four-cusp approach.
Right, it structures the conversation based on the patient's prognosis.
Okay, walk us through those four cusps, highlighting how the goals shift at each stage.
So cusp 1 is potentially curable. The goal is radical surgery with the presumption of cure. Cusp 2 is living with cancer. The focus here shifts to prolonging survival and maintaining excellent quality of life during remission. Cusp 3 is pre-terminal. This is a crucial transition. The aggressive pursuit of cure stops. Goals move entirely to supportive care and QOL improvement, and the patient is gently informed they have limited time to, put their house in order.
And cusp 4?
Cusp 4 is terminal. The focus narrows solely to supportive care, robust symptom control, and easing the passing. But regardless of the cusp, the final rule of communication is to always end on a positive note, setting short-term, achievable goals. You never want to leave a patient without hope. The operative phrase is, never say never.
We've taken you, the learner, through a monumental amount of material today. From the bedrock of safety understanding why LMWH is superior and why double gloving saves lives, all the way to mastering complex anatomy and finishing with highly specialized treatments like the LEEP procedure.
The sheer depth of information required in this field is striking. It demands an expertise that ranges from mastering foundational pharmacology all the way to executing technically superb microvascular and reconstructive procedures. For the learner, I think the key takeaway is that precision in every single step is it's non-negotiable.
With that necessary precision in mind, here is your review question and exercise to solidify what you've learned from this deep dive. You're managing a patient classified as high risk for thromboembolic disease, or TED, who requires a complex gynecologic oncology procedure, using the source material we've discussed. Number 1. Why is low molecular weight heparin LMWH preferred over standard unfractionated heparin UH in this setting? Specifically, how does it address that UH efficacy versus bleeding dilemma? And number 2, what is the dual critical purpose of transposition flaps like the Omentum or a VRAM flap in both pelvic exoneration and the core procedure? Take those points, apply that knowledge, and we'll catch you on the next deep dive.